Oral glucose tolerance test. You will see these are intimately related to diabetes. I mean, in diabetes only these two tests are done. See, this is basically, as I told you, I have shown one book on thyroid. So, for each and every disease almost there is a big book, and this diabetes book is also no less bigger than that thyroid book. Now, even if you read this book, you will not be able to understand diabetes. The more you read this book, the more you will realize the emptiness of your knowledge. That's it. It will raise at least 1 lakh questions if you read this book. So, therefore, updating is required. So, there are many journals and on diabetes, and the lecture hall, what you have seen. If all the journals are collected, perhaps the lecture halls will be full, one lecture hall will not be sufficient. That means the actual disease is not properly known. See, diabetes is a very common disease, very, very common disease, but it's a poorly understood disease. That's why so many journals, so many books, as if it is blind man describing an elephant. The disease is not yet understandable and cure is distant reality. So, diabetes is a controllable disease, it is not a curable disease. So, blood sugar normally is a loosely used term, it's a time honored term, but actually what we measure is either we measure blood glucose using glucometer, or we measure plasma glucose as a standard laboratory method. Serum glucose is not recommended. There is a difference between plasma glucose and blood glucose. Plasma glucose is 10 to 15% higher than blood glucose. Now, here, while you are using this glucometer, normally whatever glucometer we have, that glucometer is plasma calibrated, means that factor is taken into account so that you will get basically plasma glucose level. So, whether that plasma calibrated part, that two words are written in the literature or not, that you must read. Otherwise, you ask from the supplier of the machine whether it is a plasma calibrated or not. If not, then you take it as blood glucose, which will be slightly lower than this thing. Second issue, using this glucometer, using finger tip, blood is drawn by pressing. That pressing must not be there. There will be a spontaneous flow of blood that must be ensured, and the test is to be done properly. In contrast, plasma glucose is done from the vein, and there is a difference between the two. Two bloods are not same. So, this blood representing basically a mixture of venous and arterial blood, and this blood is purely venous blood. So, in fasting state, when blood glucose level is minimum, so tissue cannot utilize glucose because there is no insulin. So, the difference between this capillary blood glucose and the venous blood glucose will be minimum. Now, after meal, if the person is normal, there will be normal tissue extraction, and so venous blood, suppose from here you are taking the blood and drawing this thing. Now, while you are drawing the venous plasma, you are drawing from here. So, the entire area is being drained. So, that means whatever blood glucose is being drained into the tissue spaces through arterial system, whatever tissue is taking up, rest of the things it is coming out to the venous system. So, if a normal individual, the difference between this capillary blood and this venous blood will be minimum. In diabetes, in fasting state, not much difference, but in postprandial, means after a meal, there will be a substantial difference depending on the degree of diabetes. The more the diabetes, more the difference. Less the diabetes, less the difference. Suppose somebody is having a fasting plasma glucose of say 300, his postprandial after meal is say 500. So, here if you pick it, you will get maybe 650, but if you collect the blood from here, you may get 550. So, there might be 100 difference, there may be 70 difference, there may be 50 difference, that we know, don't know. So, that is not same. Only thing is that what you can do, best thing is if you are in a hurry to start the treatment, you draw the sample from the vein using the needle and syringe. Give the blood to the laboratory using that tube. Using a single drop of blood, you put this in the glucometer. So, the sample is same. Now, if you do it properly, if this instrument is plasma calibrated, the machine is calibrated properly, the strips are proper, you will get almost same result. Do you understand my point? There are three issues. One is you have to do it very correctly. Number two is machine needs to be very much calibrated well, and the strips are to be also very in good condition, means genuine condition. Then only you will get the result. Otherwise, no. So therefore, periodically, what you have to do, wherever you are in service or you are in job in private practice, purchase this type of machine, the low cost machine. This is called point of care testing, POCT. Write down one term, POCT means point of care testing. This type of small handheld machines are available. I mean, it is better to purchase this thing and use it because it might be required in your home. If somebody is diabetic, you can diagnose whether the patient is having hyperglycemia or hypoglycemia. That is very much useful. And periodically, what you do, whether the machine is functioning or not, point of care testing. Point of care. When the patient is there, at that point you are testing. So this type of machine, other machines are also available. Capillary, in the capillary, diabetes, because insulin is deficient, no? Because of the degree of insulin is varies widely. The more the diabetes means the more the deficiency of insulin. Less the diabetes, suppose somebody's blood sugar glucose level is 150 and PP is suppose 220, and another patient is fasting is 250 and postprandial is 375. Third one is 350 and postprandial is 575. Suppose. So here what is the difference? The insulin level is very high, insulin level is very low, progressively low. So because of the low, the fasting itself is very high. So if you give the person takes meal, then the person will not be able to lower down the glucose because there is a deficiency in the insulin. In normal individual, if you take 10 sweets, 20 sweets, because of your insulin secretion is normal, so that much glucose will be brought down. Maybe for temporarily, for some time it will be raised, but it will be brought down. But diabetic patients will not be able to do that thing. But the more the diabetes, the more the rise in blood sugar, and there will be long time to decrease that blood sugar to near even fasting level. One thing I want to highlight, see, we feel hungry because there is a low blood glucose. You allow to operate this system in your body. Until unless you feel hungry, don't take food. Otherwise, you will be obese. And that hunger satiety center will be lost. Similarly, in today's life, whatever you are seeing, we are having 1 or 2 child norm. And before the baby, cries for food, the mother gives the food. She gives the food based on the clock, not on the child's hunger. সকাল 9টার সময় খেতে দিয়েছি, খেয়েছে, এখন 10টা বেজে গেল, এখন খিদে পাবে না, ও বলতে পারে না, বলে দেয় না না না, ছেলে যদি খিদে পায়, বাচ্চা যদি খিদে পায়, সে কাঁদবে, 2-3 বার কাঁদতে দেবে, the system অপারেট করবে, patient will not be that much obese. And because of this thing, we are inducing obesity, and ultimately the baby is going to have diabetes very shortly in the young age also. So that you must prevent, and for your own protection, I am telling you, since you are professionally in this line, you will be under tension. So in course of time, you are likely to be diabetic. I have become diabetic, honestly speaking, after 55 years of age, and also become hypertensive because of the tension. So tension will be an integral part to try to prevent the disease whatever way you can. And this is the way, one way is to reduce the calorie intake as much as you can, but of course without compromising your daily activity. So MIA term is used to indicate whatever is present in the blood. So basically you have seen anemia, less hemoglobin, thalassemia, polycythemia. So glycemia here presents a level of glucose in blood. That is called glycemia. So we are coming across 3 terms. One is hypoglycemia, one is normoglycemia, one is hyperglycemia. So instead of saying blood sugar, blood glucose, plasma glucose, it will be wise and most medically correct is normoglycemia. We are normal individuals are normoglycemic. The patient will be either hyperglycemic or the patient will be hypoglycemic. So when the patient is hyperglycemic, your target is to restore to normoglycemia. When the patient is hypoglycemic, the target is restored to normoglycemia. So what you say, the patient is not yet normoglycemic. Patient is still hyperglycemic. Patient is still hypoglycemic. Patient has not yet achieved normoglycemia. That will be a proper term rather than blood sugar এখনো ঠিক হয়নি কো, plasma glucose এখনো ঠিক হয়নি কো। কারণ blood sugar করছে না, plasma glucose করছে না, normoglycemia বলে দিলে মানে normal glucose level in the blood, that will indicate. That is the reason I have told you. So, diabetes mellitus patient usually suffers from hyperglycemia. That is the hallmark. Blood glucose level has to be high. So, this you write down this definition, and I will discuss in detail. At one corner, you write down this figure on the right hand side corner, because there will be a chart. That chart you have to remember. So, only on the top you write diabetes mellitus refers to a group of metabolic disorder that share the phenotype of hyperglycemia, because hyperglycemia has to be there. Phenotype here, you know, in the genetics part you have seen perhaps the color Mendel's law, external appearance, that is called phenotype. Here the phenotype is hyperglycemia, because that is being observed clinically, but problem is there in the gene, problem is there in the insulin, but because of the deficiency of the insulin, the manifestation is hyperglycemia. Like blood group, there is a gene for O group, A group, AB group. The genotype is that gene, but the phenotype is expression of that, whether A group antigen is expressed or B group or AB group, that is the phenotype. So, this is characterized by three things. One is more than 126 or equivalent to fasting and PP 200 and H1C. I will repeat once again. Don't be hurry right now. Just remember this thing. I will repeat this slide once again. So, there should not be any calorie intake. You see, I have written here asterisk. There should not be any calorie intake in last 8 years. That is the fasting state. Means the patient has to take a last meal in the last evening or night. At least there should be a difference of minimum 8 hours. I prefer to ask the patient to remain for 12 hours. The reason is that patient might adjust it. So, you ask the patient, the most logical part will be try to inquire from the laboratory from when the blood will be taken and from where the patient will come. Accordingly, you schedule her last meal for in the preceding night, and the PP is done after 2 hours with 75 grams glucose for an adult weighing more than 45 kg. Those who are weighing less than 45 kg, we have to measure in 1.75 gram per kg body weight up to a maximum. This you must remember, and this you write down. This you have to remember. This will be up. This is as per ADA 25 and WHO 2020 criteria. What is this thing? I will explain. So, what are the clinical features of diabetes? See, this is basically the patient will complain of polyuria, polydipsia, polyphagia. Why polyuria? Because patient will pass poly means multiple times. Means multiple times he will pass the urine. Why? Because there will be hyperglycemia. There will be glycosuria. Because of the hyperglycemia, it will cross the renal threshold, and because of the crossing the renal threshold, glucose will appear in the urine. And glucose is an osmotically active substance, it will draw more water. So, therefore, the more the diabetes, the more the glucose in the urine. So, therefore, the patient will have the more volume of urine, and he will feel the urge, he or she will feel the urge to pass urine. That is the reason polyuria. So, polydipsia, because high volume is also lost along with the urine. So, patient will feel thirsty. So, that is polydipsia. And polyphagia means multiple times eating many times normally and good amount of food. Why? Because in diabetes, because of the insulin deficiency, although glucose is present in abundance in the around the cell will not be able to utilize that glucose. So, therefore, cell will basically undergo starvation. So, there will be less amount of glucose in the cell, and cell will not be able to produce adequate amount of ATP, and that will stimulate that hunger center to take food. In starvation, in contrast, there is real deficiency. Glucose is not there. So, cell cannot take. Here, cell is unable to take. So, one thing I want to highlight, these type of symptom will be there when the disease is very advanced. When the plasma glucose level, even in fasting level will be 400, 300 like that, and PP plasma glucose will be around 600, 700, 800. It is not found in the early cases, because body gets adjusted to the changes. Suppose we are having, today I am having normal glycemia. Diabetes will not happen overnight. It will happen over a course of period of or years. So, body will get adjusted to it. Suppose you are climbing say 20 staircase, you are not feeling any problem. Now, I have increased one step more. And if you allow it to walk you for another 1 month, now your body will get adjusted to it. Now, if I add one step more, another 2 months. So, in course of time, even if I allow in this way, it's about 20 steps. So, whatever you are walking comfortable with 20 steps upstairs, you will not feel any problem even if you cross 40 steps. So, that's why the body gets adjusted to it. Now, there must be a limit of everything. So, that limit when it will be exceeded, then the patient will have this type of symptom. So, as in the diabetes also, there is a high renal threshold because of the corresponding glucose is filtered normally and that normal filtered glucose is absorbed. My body will try to reabsorb the glucose as much as it can because glucose is a very precious substance, valuable increased substance, so body will not allow it to pass through. So, the renal threshold will also be increased in some diabetic patients. So, even if the blood sugar, we say that it is 180 milligram per deciliter, in many cases, you may not find any blood glucose level, even sugar level, even if suppose if patient is having 250 blood sugar level, but even sugar may not be present because there is renal threshold. That one case I have, and I have had many such cases. The renal threshold was high. Second, third point, unexplained or unintentional body weight loss. Suddenly, a patient is normal and for last 3 to 4 months, he has started losing weight. Why he has started losing weight? Because glucose is basically a metabolically active substance. That substance is being lost. So, therefore, the body is losing its energy and that is causing unintentional weight loss. Unintentional means you are not having any intention to weight loss. You are taking the same food, same exercise, doing the same thing, but there is a loss of body weight. So, once somebody is losing body weight, at least you try to find out 3 things. One is diabetes, second one is cancer, third one is tuberculosis, fourth one is hyperthyroidism. So, these first 2 things you must rule out. One is diabetes, commonest, and second may be an underlying cancer because metabolic cancer cells are metabolically active. So, it is drawing that glucose. Third one is tuberculosis, chronic infection, and fourth one may be hyperthyroidism because other features will be there. So, blooding of vision, why? A lens is suspended in the aqueous humor. That aqueous humor is having glucose. That glucose basically is dependent on plasma glucose. So, the more the blood glucose, more the plasma glucose in the aqueous humor. So, if you suppose if you take a grape and if you put it in the distilled water, the grape will swell and burst. If you just like hypoglycemia, suppose, and if you put it in just a very concentrated solution of juice, that grape will shrink just like it will become something like kismis type of thing. So, it will be it will be basically shrunken. So, because of that thing, there will be blurring of vision. Lens will not be able to focus that much amount of light. So, and second is chronic recurrent infections. Patient will have boils, wounds here and there. Means because the bacteria are getting good amount of nutrition and they are growing it. So, despite antibiotic, patient will not have be cured or will be having a recurrent infection, or there will be improper wound healing. Wound heal করতে চাইবে না কিছুতেই, আমি তোমাকে বলে দিচ্ছি যে যখন এরকম দেখবে কেস, আমি in a short while you will see the picture. But one thing you remember, most of the patients you will see in the OPD indoor, they are totally asymptomatic. These symptoms what I have shown, they don't have any symptom. Casually on routine investigation, this disease is diagnosed and the patient do not want to accept the disease because they don't have any symptom. It happens to medical care professionals also. The body got adjusted. Suppose you are having right now 600 medical students. Now all of you are from almost above middle class family or upper part of the middle class family. Now you take some amount of food much more than what you do the real exercise. So if I do the blood glucose testing or diabetes screening of the 600, I am telling you at least 5 to 10% students will come out to be diabetic. And some at least 30 to 40% person might be in the intermediate range, and maybe 50% to 60% will be normal. So I will emphasize on this point. Periodically, what I would suggest, since you are in this profession and the investigation facility is with you, at least get yourself checked up once every year, so that even if you develop the disease, you can reverse this process to normal. Otherwise, if you do not do this thing, you will be diagnosed with the disease when the disease is quite advanced. So at that time, it will be very difficult to control the disease without medication, and you cannot bring it to normal. So presentation with complications. Even since the patient is asymptomatic, so the patient will not come. So when they will come with the complications. And you see the complications, either there will be diabetic cataract, premature at the age of 40 years, 45 years, there is a cataract formation, or there is a retinopathy, retinal damage is there, retinal hemorrhage is there. Means now it is basically irreversible. You cannot do much about the patient. Patient will present with nephropathy, renal failure. One case I will say to you, straight away needs dialysis. Or diabetic ketoacidosis we have heard, and hyperosmotic, hyperglycemic hyperosmotic syndrome, aged patient might come. So this type of wounds, if you see in a OPD or indoor setup, you see the chronic lesions. So immediately let's think of whether the patient is diabetes or not. Have a blood glucose level measured. So this is oral. If you put the term, a full fungal infection, this is candidal infection, oral SARS. Once you see the patient, you will never forget. Candida infection is very common in diabetic patients. So if you look at the even genital part, vulvophageal candida, same thing what is happening in the oral cavity. Still we are washing that genital area. We usually do not all wash regularly, maintain hygiene. So there is a high chance that there will be candidation. If you put one speculum and if you see, we will never forget only a single case. Same thing will happen with the male persons. So they will present with this thing. Once you find this thing, always rule the genital candidiasis, rule out diabetes. Third is ulcer. Advanced cases, they try to neglect. And this part you see the gangrene, this part you see the gangrene, it needs amputation. Otherwise the patient will die. So these are the patient presenting with the complications of diabetes. So in the eyes, there will be exudate, there will be hemorrhage, there will be microaneurysm. Now these are the stages where this is basically irreversible. At that stage you can bring the disease somewhere at this stage, but this is within that arrest of that stage is not possible. So don't allow this thing to occur. Try to prevent as much as you can. So criteria for diabetes is done by two basically methods. Earlier, when we were students or we were postgraduates, World Health Organization used to give guidelines, and first guideline was given in 1985, and then 1994, latest guideline is in 2020. Now nowadays everybody is following American Diabetes Data Association guidelines, and they started giving every year from 1997 to 1995. Every year they publish the guidelines in the month of January. There they give the guideline for what is the plasma glucose, fasting and postprandial level, what is the HbA1c level for diagnosing diabetes mellitus. Postprandial means after meal. Since we are not giving meal, we are giving glucose. Usually I write it is PG, means post glucose. Post meal, if you PP, whenever you are doing in real practice, you see write down PP, post glucose. Or if it is a post meal, post lunch, post breakfast, whatever the patient has taken, so that you understand what is the PP plasma glucose level. Because breakfast quantity and quality is different, lunch quality and quantity is different. Therefore, the postprandial value after 2 hours of lunch and breakfast will differ considerably. Somebody has taken dosa, somebody has taken luchi powder, somebody has taken mudi, aloo dom, খেতে পারে অনেক কিছু খেয়ে দিয়ে দেবে। তো নোট ডাউন করে রেখে দেবে কি খেয়ে দিয়েছিল, কারণ পরবর্তীকালে তোমার কাছে আসবে পেশেন্টটা, you have to interpret accordingly. The same খাবারটাই খেয়ে করবেন, যে খাবারটা খেয়ে আজকে করলেন, এরপরে যখন ব্লাড সুগার করবেন রিপিট করে আবার ওই খাবারটাই খেয়ে করবেন। যদি ঘুগনি মুড়ি খেয়ে করে ঘুগনি মুড়ি খেয়ে করুন, যদি ধোসা খেয়ে করে ধোসা খেয়ে করতে বলবেন। কারণ তাহলে তুমি কম্পেয়ার করতে পারবে যে তুমি যে ট্রিটমেন্টটা দিচ্ছ ট্রিটমেন্টে রেসপন্ড করছে কিনা। মানে সেদিন ভাত খেয়ে দিলে আর সেদিন মুড়ি খেয়ে দিয়েছিল হবে না, তুমি ম্যাচ করবে না, এইগুলো খেয়াল করে রাখবে তুমি। আচ্ছা দেখো এই এখন এই ইন্টারনেটে ডাউনলোড করে দেখতে পারো 1985 WHO কি বলেছিল। Only to collect this paper I had to go to Delhi National Medical Laboratory to collect this journal, and this again 2020 you see WHO guidelines is there. You can download it from the internet, you can see it, go through what was the picture historically. Now one thing I would like to say, this is standard guidelines, ADA guidelines, that is American Diabetes Association guidelines 2025. So every year in the month of January they publish the data, and they give several guidelines of what is the criteria for diabetes, how will you manage it, what will be the diet, what will be the dietary medical prescription, what is the insulin dosage. So what I would suggest you that you read while you are in 5th year class, maybe in 2028, you download this book, this booklet, and read thoroughly. Note down, make a note down of whatever points are there, and when you will be appearing for the NEET PG, you just open that latest edition, maybe 2026, and you see what are the changes there. Usually the changes are not in the major part. You see, look at the tables, look at the charts, and then এটা পেয়ে যাবে তুমি বইতে, কোনো ছবি তুলে দেখো না, আমি সব দিয়ে দেবো তোমাদের। এই ক্ষেত্রে পড়বে, যেগুলো বলছি সেগুলো শুনে নাও। These footnotes you must read. The changes are made here, which are overlooked, and questions are usually set from this type of question. That's what I used to do. I adopted this policy during my entrance also. Of course, it was not there, but some other. See here, the ADA 25 guidelines and ADA 2021 guidelines, you will not see anything here. But if you look here, you see there is a difference. What 21 guidelines says that you see this plasma glucose fasting or PP or HbA1c or a random glucose of more than 200 or. But if you look closely, you see what is written here. Diagnosis requires two abnormal results from the same sample. Means if you take a fasting, if you take a PP, or if you take a random, you measure once, and if the value is high, measure once again. Means 2 times you have to read from the same sample, or 2 separate test samples. Means whether it is fasting 2 times or PP 2 times, it is not well defined. In 2025 guidelines, you see diagnosis requires 2 abnormal test results, means not 1, or on the top or is written, but here you require 2 tests. 2 abnormal test results from different tests, means not same, fasting PP or fasting HbA1c or PP HbA1c or fasting PP. A different test which may be obtained at the same time. মানে আমি এখনই একবার তখনই নিলাম, নিয়ে আমি করলাম, হয়তো ফাস্টিং ব্লাড গ্লুকোজ দিলাম, দিয়ে HbA1c-টা তার সাথে অ্যাড করলাম, PP ব্লাড সুগার দিলাম, তার সাথে HbA1c-টা অ্যাড করলাম। Or the same test at 2 different time points. Means with 2 separate test samples and 2 different time points. See, there is a difference. So even after 2025, sorry to say that we are yet unable to define what the diabetes is. So there are many experts of diabetes that there are many self-proclaimed diabetic experts that nobody can cure the disease. They can control the disease at the best. Diabetes is not a curable disease. So HbA1c, you write down everything. See, first you understand. See, if I take fasting, if I take postprandial, if I take random, means right now I am taking the blood. So I am taking a blood at a given point of time, maybe at 9 o'clock, 9 minutes, 29 hours, 20 minutes, 31 seconds. That is a point of time. PP I am collecting at 11 o'clock at 40 minutes, 34 seconds. So that is a point of time. Random, I am collected random. So that is a point at that particular point of time, what is the blood glucose level. But I cannot know what is the blood glucose level of last 2 to 3 months. Now you write down every point and try to memorize. This might come as a short note, and this is basically taken from your clinical book, and you have to remember, I mean lifelong. There is no excuse, because this test is a very common test, and HbA1c fascination is there. So everybody wants to do HbA1c, and you must know each and everything of HbA1c because interpretation is required. So normally the RBC is having a lifespan of 120 days, provided the patient is normal, provided there is no hemoglobinopathy. If there is a hemoglobinopathy, then the lifespan will not be same. Lifespan will decrease. And the patient is otherwise normal, means he does not have any other medical abnormality which will hasten RBC lysis, lifespan. So you see, remember, HbA1c is a long-term assessment of last 10 to 12 weeks or 2 to 3 months. Means, see, we are just think of yourself, you are remaining, taking a lunch, morning lunch you have taken, before that you were fasting, so your blood glucose level was not same. After you have taken breakfast, your blood glucose level has increased. Now before lunch it has decreased. After lunch you have taken again a food, again there is an increase. Again in the evening you are taking tea and snacks, again there is an increase. And before dinner also there is a fall, and again after dinner there is a rise. So that total average, that 24 hours average will be given by HbA1c, and out of the total value of HbA1c, whatever you will get, 50% will represent for last 1 month, because RBC is 120 days lifespan. So right now, some of the RBC will be today 121 days, who will destined to die. Somebody is having 0 day. Today it has been produced from the bone marrow. Some will have 10 days, some will have 20 days, some will have 34 days, some 84 days, some 95 days, some 150 days. So there will be mixture of all these things. But 50% of the HbA1c will be representing the last 1 month of RBC production. What is the level? So basically there are two terms. One is glycated hemoglobin, that is normal, non-enzymatic. HbA1c represents the glycated hemoglobin, not glycosylated. Glycosylated means you require an enzyme, that is glycosyl transferase, enzyme will be required. So it is not glycosylation, it is a non-enzymatic reaction, that is glycated. Try to remember this thing, and this you write down this particular word. What is glycosylated hemoglobin? You just say that it's the alpha amino group of N-terminal valine, moiety of beta chain. Beta chain is present in normal adult hemoglobin. So beta chain is non-enzymatically glycated. It forms a skip base. Initially it is in the reversible form. In the next slide you will show, and it is based on the ambient blood glucose formation. Now if that blood glucose level is maintained for quite some time, suppose you have taken 20 rasgulla or 30 rasgulla or a good amount of sweets today, there will be a sudden rise of blood glucose for today, and it might persist for maybe tomorrow, but thereafter it will not there. That will reflect that reversible form, but it will not show the HbA1c level. HbA1c level will not be counted, because that level has to be maintained for quite a long time. Then that reversible form will be converted into irreversible form. Since diabetic patients do not know, and their blood glucose level is maintained at a higher level for quite some time, so that reversible form gets transformed to irreversible form, and it is the irreversible form which we measure as glycated hemoglobin as HbA1c, not the reversible form. The albumin form is the reversible form. Ketamine form is the irreversible form, and we measure ketamine form. So basically, HbA1c is a matter of basically ketamine form of beta N deoxy fructosyl component of hemoglobin. Even if you cannot remember this thing, forget this thing. Don't remember. Write down this part. Only thing, write down skip base, Amadori rearrangement. It gets a stable form, and just like glucometer, there is one HbA1c meter also. But this is a low cost instrument. It will not give that perfect result, but if you are really in a hurry and to diagnose the case, you can carry also this point of care testing also. This is also a POCT. But if you want to measure, advice for any patient that glycated hemoglobin, you go for HPLC method. No, there are other methods, colorimetric method, autology methods are there. If you want to get the correct report, you go for a high-end machine of HPLC, because that will give the better result. Because as you know, there in camera, there are low-cost camera, there are high-cost camera, and the quality of picture is different. Same thing will happen. There those who are having a high cost machine of HPLC, that will give a more closer value of HbA1c. So if the test is to be referred and it is to be done, it will be done properly. Otherwise, don't do the test, because giving a wrong report is more dangerous than giving no report. That's what I feel personally. এটা লেখা গেছে দেখো তো। আচ্ছা দেখো, এটা মনে রাখতে হবে না, এটা দেখাও, বাস কিছু মনে রাখতে হবে না, এইখানে শুধু এটুকু লেখো। এটা লেখো গ্লুকোজ, এইখানে লেখো এই স্ট্রাকচারে লেখো HCO, হিমোগ্লোবিন এ ভ্যালিড NH2, এটুকু লেখো, দিয়ে লেখো গ্লুকোজ। এইখানে দুটো অ্যারো দিয়ে দাও, রিভার্সিবল ফর্ম লেখো, এইখানে দাও, শুধু এই স্ট্রাকচারটা শুধু এই জায়গাটা চেঞ্জ করে দাও, বাকিটা গ্লুকোজের স্ট্রাকচার লিখে নেবে। ওই অ্যামাডোর এইখানে লেখো অ্যালডিমিন ফর্ম আর স্কিপ ফর্ম, একটা সিঙ্গেল আলাদা অ্যামাডোর রিয়ারেঞ্জমেন্ট, এই কিটামিন ফর্ম করে এখানে ছেড়ে দাও, ব্যাস শুধু এইটুকু স্ট্রাকচার লেখো, তাহলেই হবে। এই উপর পার্টটা এই দুটো লাইন লিখে দাও। আর এইটা যেন লেখো গ্লুকোজ টু অ্যালডিমিন ফর্ম স্কিপ বেস to ketamine form H1C, this amount of reagent. So we are in H1C, we are not measuring albumin form. We are measuring the ketamine form, which is irreversible. That means blood glucose has to be maintained for quite a longer period of time. Okay? হয়েছে? একটু তাড়াতাড়ি লিখে না, অনেকটা জিনিস আছে বলতে হবে। এগুলো একবার বই থেকে পড়ে নেবে, তাহলেই হয়ে যাবে। কারণ এটা লাগবে, সারা জীবন কাজে লাগবে। আরে লেকচার তো ভিডিও রেকর্ডিং পেয়ে যাবে, সুতরাং এখন শুনে না শুনে হয়েছে। আচ্ছা এইবার দেখে না, এই শুধু এটি লেখো হোয়াই HbA1c, হোয়াই ইউ আর মেজারিং HbA1c। So HbA1 constitutes of 95% of Hb. Basically the glycated part of the HbA adult hemoglobin is the HbA1. So that is constituting 95%, even 97%, 95 to 97% I am telling you. Out of HbA1c, 85% is HbA1c. So major amount is located in the HbA1c. That is the reason why we are measuring HbA1c, not HbA1a or HbA1b, or that is the reason why other two are not measured. Since this is present in the maximum amount, that's why we are measuring HbA1c. HbA1c, see, glucose level we are measuring fasting or PP in milligram per deciliter. But HbA1c is measured in terms of percentage. Remember this thing, unit of measurement of HbA1c is in percentage. So usually 6% corresponds to a average plasma glucose concentration of 126. Means that if the patient gives a 6% of HbA1c, means you will know that the patient is having almost otherwise normal 126 for last 2 to 3 months. Patient is not at least diabetic. If it is 7%, then with each degree above 6%, you add either 28 or 29 and you will get the actual figure for the average blood glucose. Either you remember anything, 28 or 29. Hardly matters if you add 2 or 3 more. Suppose if you add 6%, 126. Now this is 12%, means 6 minus 6, that is 6 into 28 or 6 into 29. You add with 126. That do you get my point? With each degree of rise, you add 28 to 29 to get the milligram percentage of blood glucose level. You need not remember all these things, just remember you have to multiply by 28 or 29 more than what you get above 6%. That will be easier. Even if you say that 290, if you remember 295 or 305, hardly matters. But you are getting a rough idea. The usually report gives this figure, okay? So this you have to remember because this will be asked. So if the patient presents with a suppose fasting blood sugar patient has present normal, but HbA1c level is this 11%, 10%. That means either the HbA1c level is wrong, report is wrong, or the other two are wrong, or the patient might have manipulated. Usually diabetic patients also does this type of problem. They usually, as you take high amount of anti-diabetic medicine and less blood glucose, less amount of food before they come to the laboratory, so that the fasting and PP will be very low. They can say that I am not that much having that much high blood sugar level, so I can eat. After that test, that is the policy they adopt. All the chronic patients, they become educated after some time, and they really cheat themselves only to take more amount of food at home. আমার ব্লাড সুগার তো এত বেশি নেই, আগে তো ছিল, যা এখন তো একটু খাওয়া যাক, একটু মিষ্টি খাওয়া যাক, কি আছে, ব্লাড সুগার তো কমে গেছে। So they cheat. That you have to check. That is the reason you have to do an HbA1c. So HbA1c will reflect that আপনি যা বলছেন ব্যাপারটা কিন্তু তা না, মাঝে মাঝে খাচ্ছেন, ভালোই মিষ্টি খাচ্ছেন বা ভালোই খাবার খাচ্ছেন, সেটা লুকিয়ে লুকিয়ে খাচ্ছেন, বাড়িতে খান না, সেটা ঠিক আছে, কিন্তু খাচ্ছেন তো বটে। তো পেশেন্ট মুচকি হাসবে, স্বীকার করবে না, তা খিদে পায় না, তো খেয়ে নি, কি করবো, খিদে সত্যি সত্যি পায়। তারা মিষ্টি যখনই খেতে বারণ করে তখনই দেশে খেতে ইচ্ছে করবে। সেই জন্য আমি নর্মালি মিষ্টি খেতে বারণ করি না, আমি বলি খাবেন একটু না, ওষুধ একটু খেয়ে নেবেন, তো খাবার একটু কম খাবেন, এই আর কি। অ্যাবসোলিউট রেস্ট্রিকশন করে দিলেই মুশকিল। So glycosuria Benedict test, I have told you. One thing I did not tell you, and then on that date, see, low renal threshold I have told, because the kidney will not be able to absorb that the filtered load. So there is defect in the glucose transport mechanism. So if the transport mechanism is defective, then it will not be able to absorb the glucose. So with even normal less blood glucose, less than 180, glucose will appear in the urine. So that is due to low plasma glucose, defective glucose transporter mechanism. Now, one important point I am coming, which you will be using in clinical years, you will be reading in the pharmacology, and you will be using this drug. What happens? Glucose is absorbed, transported in the proximal convoluted tubule. Now, proximal convoluted having three parts, only S1, S2, and S3. S1 and S2 part is having SGLT2 receptor, sodium glucose link transporter 2, and that is responsible for 90% of the glucose absorption by the glomerulus, and rest 10% by SGLT1, which is present in the S3 part. SGLT1 is present in the intestine for transport of glucose from the intestine into the blood circulation. SGLT present in S3 component. Now you see there what is different in SGLT2, one sodium along with one glucose. Here SGLT1, 2 sodium with one glucose. This you must remember. Biochemically. Now if I choose a drug which will inhibit this SGLT2, what will happen? If I take a medicine which will inhibit SGLT2 inhibitors very specifically, not SGLT1, what will happen? বলো গ্লুকোজ অ্যাবজর্পশন কমে যাবে, ঠিক বলেছো, গ্লুকোজ অ্যাবজর্পশন কমে যাবে। কমে গেলে কি হবে বলো? ইউরিনে গ্লুকোজ বেশি বেরিয়ে যাবে, ঠিক, গ্লাইকোসুরিয়া হয়ে যাবে। আমি যদি খাই SGLT ইনহিবিটর বা আমাদের নর্মাল ব্লাড গ্লুকোজ লেভেল যদি খাই, এই ওষুধ যদি খাই, তাহলে আমরা নর্মালি ইউরিনে গ্লুকোজ বেরোতে আরম্ভ করবে। এই ইউরিনে যদি বেশি গ্লুকোজ আরম্ভ করে কী হবে? ব্লাড গ্লুকোজ লেভেলটা কমে যাবে, ঠিক। তাহলে এই ওষুধটা ডায়াবেটিস পেশেন্টকে দেওয়া যেতে পারে, তাদের হাইপারগ্লাইসেমিয়া থাকে। নর্মালি এই ওষুধটা দেওয়া হয় না নর্মালি, কারণ গ্লুকোজ ইজ এন এনার্জি রিচ সাবস্টেন্স, অ্যান্ড পার্সোনালি আই ডোন্ট want to use this thing until unless compelled. Because glucose is an energy rich substance. If you allow it to pass through body, patient is going to lose body weight. When the diabetes cannot be controlled by the conventional medicines with the maximum dose, whose basic function either to increase the production of insulin or to utilize the insulin by different mechanisms, or to sensitize the peripheral tissue to insulin, available insulin. Now, when that fails, and the patient is overweight, patient cannot control the body weight because of the genetic propensity, genetic makeup, patient is unable to control the body weight. Now, as I have told you that if you give the blood glucose like this to the obese patient or to the patient who is having a high blood glucose who cannot be controlled, there will be induction of this SGLT2 will be inhibited, and there will be selective inhibition, there will be glycosuria, and that will cause lowering of blood glucose level, and it will facilitate weight loss. Now, once this weight loss is maintained in diabetic patients, control of diabetes will be much better with the other drugs. So, these SGLT inhibitor you will be using in the clinical setup also. Remember one thing, when you are giving this thing, one particular advice is to be given to the patient. What advice you will give to the patient? A specific advice is to be given when you give. Don't forget to mention this thing when you are advising it, prescribing this medicine. Tell me, what will happen? বলো জল তো বেশি খাবে, ঠিক আছে, জল তো বেশি খাবি একদম, বিকজ ইউরিন বেরোচ্ছে গ্লুকোজ, একদম ঠিক বলেছে। ও তো জল বেশি খাবে, জল চেষ্টা পাবি, কিন্তু তোমাকে একটা ইনস্ট্রাকশন দিতে হবে। হ্যাঁ, চকলেট রাখতে বলতে ঠিক আছে, হাইপোগ্লাইসেমিয়া হয়ে যেতে পারে, কিন্তু ইউজুয়ালি ওইরকম কিছু হবে না। কেন বলছি না, ও পেশেন্টের ব্লাড সুগার অনেক হাই থাকে, হতে পারে, শোনো ও যেটা বলছে এটাও ঠিক, কারণ তার ব্লাড সুগারটা হাইয়ে সেট হয়েছিল বডিটা, সাডেনলি ড্রপ করছে। তো যদিও ব্লাড সুগারটা বেশি থাকে, তাহলেও কিন্তু পেশেন্টের সিমটম হতে পারে। দিস ইজ কল্ড রিলেটিভ হাইপোগ্লাইসেমিয়া। although the patient is hyperglycemic, but since there is a rapid drop, body will not be able to adjust it. So patient will have a hyperglycemic symptoms, as if his blood sugar glucose has come down. It happens. It happens. What he has told. One more thing. Huh? Bola. UTI channel patients. All glycosidic patients are suffering from UTI. Remember, urinary tract infection is very common, particularly in females. So here, what is he advised? See, genital candidiasis you have seen. So there will be growth of fungus. So after passing urine, advise the patient to properly wash the genitalia so that the entire glucose is washed out. Because invariably glucose will be present in that in high amount. Those who are excreting having glycosuria, that they are maintaining. Now you are giving an extra dose of glucose to allow the more glucose to come out. So good amount of sugar will be there around the genitalia, and the patient will come out with the candidiasis or genital infection or urinary tract infection, what she said. So advise that patient to maintain that thing. Personal hygiene maintenance. So this is coming to the glucose tolerance test. See, tolerance means we are giving glucose and we are checking how much the patient is going to tolerate that amount of glucose. Now this chart you remember, this you have to remember the entire whole thing. So I have said this part. Diabetes mellitus. This part was told. Now this part you write down, forget about this minus sign. Write down what is normal. Three columns you make. 3 columns you make. One you write down fasting plasma glucose. Second one is 2-hour PV/PG, and third one is HbA1c. And left hand side you write down with this thing. Fasting is less than 100. PP is less than 140. And HbA1c is less than 5.7. This equivalent to, just don't write this equivalent part. This sign you off it, okay? As I told you, diabetes doesn't develop overnight. So this normal through a stage of pre-diabetes, patient will pass through and the patient will be diabetic. So you will have an area of impaired glucose tolerance. Means the value will be intermediate. It will not be normal, it will not be diabetic also. So that intermediate zone will be there. Borderline, yes, pre-diabetes, that's why it is called pre-diabetes. IGT, impaired glucose tolerance state, or pre-diabetes, means he is having a pre-diabetic stage আছে এখন নরমালটা ছেড়েছে সেটা এবার যাচ্ছে বোলপুর স্টেশন ছেড়ে মেডিকেল কলেজে আসছে অন দা ওয়ে আছে মিডলে আছে এইখানে কি ইম্পর্টেন্স আমি বলে দিচ্ছি see if you can detect the patient in this stage by aggressive control it can be brought to this stage if it is properly maintained. From my experience I am telling you, if the patient is detected at the lower part of this thing or maybe in the middle, you can by aggressive control bring it to the stage and maintain it so that you maintain normal blood glucose. Now, if the patient is diabetic, to be very frank and honest, even with medication, you will come to the at the best lower end of this one. At normal, absolute normal things, of all the things, all the parameters, all the time, it will be very difficult. So that is the reason why I am asking you to undergo yearly checkup. So that even if you have detected in this stage, you can reverse your disease to normal and maintain that thing. Because you will realize that you are going to have diabetes. And those who are women, I would advise you to be very stringent on this because one day you will be pregnant. And pregnancy is a risk, potential, risk factor for developing diabetes, those who are having that propensity. And usually diabetic pregnancy is a bad pregnancy, I would say, because outcome is bad, baby is likely to be abnormal. So diabetes needs to be aggressively controlled during pregnancy. So even if at the time of conception, if the blood glucose level is high at the time of conception itself, the baby is likely to be genetically abnormal. There will be some malformation. So be very careful about treating a pre-pregnant woman. Advise her properly. Okay. So this is the criteria. And another criteria I have written, that if random blood glucose is more than or equivalent to 200, that you write down. Apart from these 3 points, random blood glucose is also there. That is more than or equivalent to 200. That is the same thing. What is the PP value? So either of the 4 you can diagnose, but usually 2 values are required. So better go for this thing. In a hurry, when your patient is admitted in the ward, you need to diagnose this case, then you do the random test, because fasting PP is not possible during that period of time. But before giving any fluid or giving any medication, do the test first. So these 3 you note down of glucose reabsorption, proximal convoluted table, GFR is 125 ml per minute, renal threshold is normally 180 milligram per deciliter blood glucose. Beyond that, it is in diabetes mellitus, urine is filtered, and transport maximum of glucose is 375 milligram per minute. It will come out as a question, MCQ question, or also it may they may ask you in the Viva. Okay. So what are the indications of glucose tolerance test? Number 1. When the plasma glucose level is unequivocal, fasting is normal, postprandial is IGT, you don't know whether the patient is normal or IGT, whether the patient is IGT, fasting, and PP, postprandial is diabetes. You are somehow confused. In that case, that is required. Whether the patient is really having diabetes, to either to establish or to exclude. You have to do this test. Second, pregnancy, as I told you, is a valuable period of time in a woman's life. So during pregnancy period, this blood glucose level has to be, this oral glucose tolerance test is to be done to see whether the patient is diabetic or not. Whether the individual is not patient, say pregnancy is a normal physiological phenomenon. Second, epidemiological study. Third, we want to know how many diabetic patients are there in Bolpur town, how many patients are there in Birmundu district, how many in West Bengal, how many diabetic patients. That is an epidemiological study, we can do it. What is the actual prevalence of this disease in this particular geographical region? And to diagnose diabetes or impaired glucose tolerance test, that has to be confirmed, as I told you, evaluation of glycosuria. Suppose urine glucose is there, present is there, but blood sugar is normal. Now, what is the reason why the glycosuria is there, but there is no blood sugar glucose level, fasting, postprandial are below 180? Ideally, there should not be. So then we have to investigate. And I am having several such cases. Because of the shortage of the time, I will not be able to show it to you. I have evaluated and have found out the cause also. Mismatch between glycemia and glycosuria. Suppose blood glucose level is 220 fasting, PP is 250. But urine sugar is coming out to be normal. This is a confusion again. Now we have to detect it. You get my point? So even if fasting is normal, suppose 175 or 170, PP is 350 or PP is 145. That can also happen. But still you are having a glucose in urine. So these are all confusing cases. So to rule out that thing, you have to do the test. And you will be doing this thing. And as a routine before any surgery, particularly any major surgery. Why? Yes. See, exactly. No surgeon will do an operation, routine operation, without evaluating for blood glucose level. Until unless blood glucose level is restored to normal level, this means normoglycemia, the surgeon will not put any incision, whatever the pressure is. He can explain under pressure that I can do this thing, but there is a chance that wound healing will not be there, or you need aggressive treatment, emergency situation. Suppose operation has to be done, you do the operation for life-saving procedure, then aggressively treat the patient with insulin. There is no other option, you have to give insulin. So, but elective surgery, major surgery, particularly any surgery, major elective surgery means planned surgery. 2 दिन পরে করলে কোনো অসুবিধা নাই। কিন্তু ঘাটাতে শুকলে ঘাটাতে শুকবে না, পার্টিকুলার পেটের ভেতরে যদি কাটো কিন্তু ইনফেক্টেড হয়ে যাবে। অ্যান্ড পেশেন্ট প্রেজেন্টিং উইথ কমপ্লিকেশনস অফ ডায়াবেটিস, স্ট্রেট পেশেন্ট এরকমভাবে খাওয়া নিয়ে চলে আসছে, চোখে হেমারেজ, ক্যাটারাক্ট, রেনাল ফেলিওর, তো তখন তোমাকে করে দেখতেই হবে যে ডায়াবেটিসের জন্য নয় তো, নাকি অন্য কিছু ডিজিজ আছে। There are many causes of that, a leg ulcer, whatever I have seen. The common cause you have to rule it out, because if you do not control diabetes, infection cannot be cured. So preparation, this part no doctor advises. আপনি ফাস্টিং পিপি করে নিয়ে চলে আসবেন, আপনি লিখে দিলে ফাস্টিং পিপি রেজিমেন্ট লিখে দিলে, তুমি ব্যাস লিখে ছেড়ে দিলে, টেকনিশিয়ান গেলে আপনি কালকে খালি পেটে চলে আসবেন। কিন্তু প্রপারলি কেউ ইনস্ট্রাকশন দেয় না, পেশেন্ট আলটিমেটলি রিপোর্ট নিয়ে তোমার কাছে আসবে। সেই জন্য তোমাকে একটু টাইম স্পেন্ড করতে হবে পেশেন্টের পিছনে, এটুকু তোমারই দায়িত্ব, কারণ পেশেন্টটা তোমার, সব কিছু দায়িত্ব তোমার, এইটিকে তুমি ইয়ে করতে পারবে না, সার্চিং করতে পারবে না কোনোভাবেই। সাপোজ আমাদের এই কান্ট্রিতে কি হয়, সাপোজ মুসলিমরা 1 মাস রমজান করে, হিন্দুরা আজকে পূর্ণিমা, কাল অমাবস্যা, পরশু এই পুজো মা ষষ্ঠীর পুজো, অমুকের পুজো, দুশুকের পুজো, উপোস করতেই থাকে। এই সব অবস্থাতে কিন্তু ব্লাড এই টেস্ট করবে না কিছুতেই। তো পেশেন্টকে বলবে অ্যাটলিস্ট নর্মাল প্রিসিডিং 3 days, কারণ এটা ইমার্জেন্সি কিছু নেই, প্রিসিডিং 3 days যেন নর্মাল খাবার, নর্মাল ফিজিক্যাল অ্যাক্টিভিটি করে। ভোজবাড়ি খেলো, আগে যে ঠিক আছে বোলপুর যাচ্ছে, সুগারে যাবো, মেডিকেল কলেজ যাবো, করে নিয়ে আসবো, তার আগে নেমন্তন্ন বাড়িতে আছে, ভোজ বাড়িতে, বিয়ে বাড়িতে খাবো, 5 দিন সকালবেলা করে নেবো, না হবে না। এসব বলে দেবে পরিষ্কার যে অ্যাবনর্মাল রেজাল্ট পাবেন। আপনি আগে 3 দিন কমসে কম যেটা নর্মাল কাজ করেন, নর্মাল খাবার খান, সেরকমই খাবার খাবেন, নর্মাল কাজকর্ম করবেন, তারপর টেস্টটা করবেন, ঠিক আছে? এইটা তুমি কমসে কম বলে দেবে ফর অ্যাটলিস্ট 3 days, তাতে বডিটা ক্যালিব্রেট হবে। আর যদি কোনো ওষুধ খায় তো তাকে বলবে যে ওষুধগুলো ইন্টারফেয়ার করতে পারে, সেই জন্য ওকে বলবে যে অ্যাকচুয়ালি ওষুধটা আপনি চেষ্টা করুন এই 3টে দিন, যেগুলো রাত্রে খান 10টা বা 10টার পরে খান, সেগুলো আগে 8টার আগে খেয়ে নিন। তাহলে হবে কি, পরের দিনের সকালবেলা দেবে, এই ওষুধের ইফেক্টটা চলে যাবে। যতটা পরে ম্যাক্সিমাম মিনিমাইজ করতে পারবে, তুমি অফ তো করতে পারবে না, তো 3 দিন আগে থেকে যদি একটা 1 ঘন্টা 2 ঘন্টা আগে পেশেন্টটা খায় না, সকালবেলা থেকে করে দেয়, পেশেন্টটা করতে পারবে, তারপরে আবার ব্লাডটা দেওয়ার পরে করতে পারবে। সেটুকু তুমি বলবে কী কী ওষুধ খাচ্ছে, কারণ ওষুধ ইন্টারফেয়ার করে। সেকেন্ডলি ওভারনাইট ফাস্টিং করবো, 8 hours লেখা ছিল ওখানে, তুমি যদি 8 hours-ই বলো, তাহলে পেশেন্ট আমাদের ঘড়ি ধরে 8 hours-ই করবে, রাত 8টার সময় খাবে, রাত কারণ 8 ঘন্টা বলে দিয়েছে ডাক্তারবাবু, 12 ঘন্টা বলে দেবে, তুমি অন দ্য সেপার সাইড। আগে জিজ্ঞেস করে ল্যাবরেটরিতে কটা ব্লাড দেয়, সবাই 10টার সময় ব্লাড নেয়, ও কখন আসতে পারবে, 10টার সময় পৌঁছতে পারবে ওখানে ল্যাবরেটরিতে, 10টার সময় ব্লাড নেবে কিনা, তো বলে 11টার সময় দেবে, তারপরে আগের দিন মোটামুটি 10টার মধ্যে খেয়ে নেবে, তাহলে হয়ে গেল, টাইমটা হয়ে গেল মোটামুটি 10 থেকে 12 ঘন্টা। তুমি 12 ঘন্টা যদি টার্গেট করো, তাহলে +- 2 hours তুমি দুদিকে পেয়ে যাচ্ছ, পেশেন্টও করতে পারবে ওটা। তাহলে 8 ঘন্টা মিনিমাম চাই, সেই 8 ঘন্টা পিরিয়ডে তাহলে কী করবে, জল খেতে পারবে, অন্য কিছু খাবার কিন্তু খেতে পারবে না। সকালে ওটা কমন কোশ্চেন, চা খেতে পাবো না, চা খেতে পাবো, তুমি সবাই দিন না করবে না, আমার পায়খানা হয় না, তোমাকে সেই পার্টটা দেখতে হবে যে ওই লোকটা দূর থেকে আসবে, সে তার সত্যি যদি পায়খানা, তার বডি হ্যাবিচুয়েট হয়ে আছে, সেক্ষেত্রে তোমাকে একটা কষান একটা এক্সারসাইজ করতে হবে। অ্যাকচুয়ালি চা খেলে কিছু হবে না, কিন্তু মানুষ চা নর্মালি খায় না, ও কিছু খেতে এগুলো, আর ঠিক আছে খাবেন, ভোরবেলা উঠে খেয়ে নেবেন, ব্যাস ওকে ওটুকু করে দেবে, চা খেয়ে নেবে চিনি ছাড়া, ব্যাস এই করে দেবে, কিন্তু আর কিচ্ছু বলবে না। আচ্ছা, এরপরে যেটা হচ্ছে গিয়ে ওই পেশেন্টটা আসবে, মাঝখানে জল খেতে চাইলে জল খেতে দেবে, তো জল আপনি খেতে পারেন, চেষ্টা করলেই জল খেয়ে নেবেন, কোনো অসুবিধা নেই, জল। তারপর ফাস্টিং স্যাম্পলটা কালেকশন হবে। এরপরে 75 grams গ্লুকোজ ফর অ্যান অ্যাডাল্ট, নর্মালি গ্লুকোজ 75 grams গ্লুকোজ পাওয়া যায় না, রিমেম্বার প্র্যাকটিক্যাল প্রবলেম, 100 গ্রাম গ্লুকোজ পাওয়া যায়, কিছু গ্লুকোজ সব আরও 20% ফ্রি, তার মানে 120 গ্রাম বা 125 গ্রাম ফ্রি আছে, 25% ফ্রি। তো এবার পেশেন্টের প্যাকেটটা নিয়ে আন্দাজে নিজের মতো করে খাবে, দিয়ে 75 গ্রাম ধরে নেবে, আন্দাজে খেয়ে নেবে। আমি তোমাকে বলি যে ম্যাক্সিমাম প্রবলেমগুলো ফেস করেছি, সেই ওকে বলবে মুদিখানার দোকানে গিয়ে 75 গ্রাম গ্লুকোজ ওজন করে প্যাকেটে, প্লাস্টিকের প্যাকেটে ভরে নিয়ে সেইটাকে নিয়ে আসবে, প্যাকেট নিয়ে আসবে, গ্লাস চামচ নিয়ে আসবে, জল নিয়ে আসবে, এটা বলে দিতে হবে তোমাকে। মুদিখানার দোকানে ওজন করিয়ে যেন 75 গ্রাম গ্লুকোজ নিয়ে আসে, আন্দাজে করবেন না, কারণ আন্দাজে করলে রিপোর্টটা গড়বড় হয়ে যাবে, কম খেতে পারে, বেশি খেতে পারে। আর যদি কম বয়স হয় 40-35 কেজি ওজন, তুমি ওজনটা নিয়ে নেবে, তুমি নিজেই লিখে দেবে যে এত গ্রাম গ্লুকোজ লাগবে, সেইটুকু গ্লুকোজ পেশেন্টকে নিয়ে আসতে বলবে। এবার ডিজেলও করবে 25 to 300 ml ওয়াটার। তুমি বলেছো গ্লুকোজ খেয়ে কিছু করতে, গ্লুকোজ খেয়ে, কিন্তু তুমি বলো না আর কিছু খাওয়া যাবে না, পেশেন্ট মাঝখানে গ্লুকোজটা খেয়ে করবে কি, ও মুখটা খুব মিষ্টি লাগবে, দুটো এখানে বেরিয়ে আসবে, শান্তিনিকেতন মেডিকেল কলেজে কথা বলছি, বেরিয়ে আসবে, সেই দেখছে চপ ভাজছে, ভালো, দুটো চপ খেয়ে নেবে আর চা খেয়ে নেবে। কারণ তুমি তো বলো যে গ্লুকোজ খেয়ে করতে, তুমি তো কিছু খেতে বারণ করে নাই কোথাও। তোমাকে বলতে হবে এরপরে কিন্তু আর কিছু খাওয়া যাবে না, গ্লুকোজ খেয়ে 2 ঘন্টা কিন্তু জল খেতে পারে যদি চেষ্টা করে। এই কথাটা স্পেসিফিক্যালি বলবে, ডাক্তার আমি তো বলেন নাই তার কিছু খেতে পাবো না, এই কথা শুনতে হয়েছে আমাকে। গ্লুকোজ 2 ঘন্টা পরে আর কিছু খাওয়া যাবে না, আপনি বসে থাকবেন, কোথাও যাবেন না, সোনাঝুরি হাটও যাবেন না, শান্তিনিকেতন ওই কলেজটা ঘুরতেও যাবেন না, বসে থাকুন চুপ করে। সিগারেট খাও, নো স্মোকিং, নো আদার ফুড ইনটেক, একদম স্পেসিফিক্যালি বলে দেবে। ঠিক আছে, এটা প্র্যাকটিক্যাল পয়েন্ট থেকে বলছি, কেন আরও ইনপুট দিল। এবার কালেকশন অফ ব্লাড আফটার 2 আওয়ার্স। এবার লাইন ওকে একটা প্র্যাকটিক্যাল টিপস দিয়ে দিচ্ছি। পিপিতে লাইন কিনা মাঝে জিজ্ঞেস করে দেখবে, ওর যদি মনে সমাজ 11টা 10 টাইম আছে, তো আমি কোনো 11টার সময় গেলে ল্যাবরেটরিতে পৌঁছে যাবে, লাইনে দাঁড়িয়ে যাবে, তাহলে ঠিক 11টা 10 11টা 10 দিতে পারবে। কারণ 11টা 10 গেলে দেখে গেলে সামনে 20খানা পেশেন্ট আছে, তো তার ব্লাড দিয়ে দিতে 11টা 20 হয়ে যাবে, 11টা 20 হতে পারে 25 হতে পারে 30 হতে পারে, যাও না। তো এগুলো একটু প্র্যাকটিক্যাল টিপস একটু বলে দেবে। আর ইমিডিয়েট অ্যানালিসিসটা সবসময় করে না, ল্যাবরেটরিতে ব্লাড কালেকশন করে টিউবে, দ্যাট ব্লাড গ্লুকোজ ভাইল আই হ্যাভ শোন ইট টু ইউ, ইন দ্যাট ব্লাড গ্লুকোজ নেওয়া হয়। বেসিক্যালি গ্লুকোজ টলারেন্স টেস্ট করা হয়, কিন্তু দুটো স্যাম্পল নেওয়া হয়, একটা ফাস্টিং আর একটা গ্লুকোজ খাওয়ার পরে 2 ঘন্টা পরে। মিনস উই আর ট্রাইং টু সি হোয়াট ইজ দ্য টলারেন্স অফ দ্য গ্লুকোজ, গ্লুকোজটা খেয়েছে নামাতে পারছে কিনা নিচে। নর্মালি at 2 hours the blood glucose value is slightly less, it is almost at or slightly below the even fasting level normally। সেটা সবাই করতে পারে না, একটু স্লাইটলি হাই থাকে, কিন্তু কিছু কিছু পেশেন্টের নর্মাল হয়ে যায়, ইভেন লোয়ার নেমে যায়। তো দুটো বেসিক্যালি আমরা গ্লুকোজ টলারেন্স টেস্ট করছি। এবার এইখানে যদি কিছু কনফিউশন হয়ে যায়, তখন তোমরা করতে হবে, এই দেখো এইটা তোমাদের বলেছি নর্মাল প্রি ডায়াবেটিস স্টেজ, এখানে এইচ কিন্তু নেই, এইটা বেসিসই তুমি ডায়াবেটিস করে দিতে পারবে, এইচ না করে দিতে পারবে। এইচ সব জায়গায় করা হয় না, তো রিসোর্স পুরো সেটিংয়ে যাবে, শুধু ফাস্টিং প্লাজমা গ্লুকোজ দিয়েই করে দিতে পারবে। আচ্ছা, এরপর দেখো, এরপরে ক্লাসিক্যাল জিটিটি যেটা করা হয় অ্যাকচুয়ালি, এখানে যখন কিছু তুমি বুঝতে পারছো না, তখন তুমি ক্লাসিক্যাল জিটিটি করবে কি, গ্লুকোজ ইনটেক করলো, খাওয়ার পরে 8 ঘন্টা অন্তর অন্তর ব্লাডও নেবো, ইউরিনও নেবো, নিয়ে টেস্টিং করবো যে কতটা রাইজ করছে। 8 ঘন্টা পর পর 8 ঘন্টা নিলাম, 1 ঘন্টা নিলাম, 1.5 ঘন্টা নিলাম, 2 ঘন্টা নিলাম নর্মালি। ইউজুয়ালি আমি একটা 2.5 ঘন্টা একটা স্যাম্পল নিয়ে নিতাম দেখার জন্য যে কী হয়েছে ঘটনাটা দেখি। এবারে এস্টিমেশন অফ প্লাজমাগুলো করতে হবে বা নর্মাল গ্লুকোজ মেথড ল্যাবরেটরি, আর কোয়ালিটেটিভ টেস্ট ফর গ্লুকোজ ভেরিডিক্ট করতে পারবে, বা ইউরিন সুগার স্ট্রিপ দেখতে পারো। প্লটিং করা হয় ব্লাড গ্লুকোজ লেভেল আর at different point of time দিয়ে ইউরিন সুগারটা কীভাবে করা হয় দেখো, এই দেখো তাকাই দিবে, এইভাবে ভালো করে দিতে থাকো। দেখো নর্মালি যে 0-1 hour, এটা ফরগেট অ্যাবাউট দিস থিং, দিস আই হ্যাভ অ্যাডেড just to show you one thing, that what is happening. See, in the first case itself, you see, look at the figure, fasting is 90, then you have taken glucose, so glucose is absorbed by the intestine, so there is rise. Now it is reaching a peak of 140. Thereafter glucose is not there, it is no longer in the intestine, it has passed through, all the glucose has been absorbed, so insulin has secreted accordingly, it is bringing the blood glucose down to this level. The importance of taking this thing is that you see the patient is sensing at this point that blood glucose level has come down, so no more insulin needs to be secreted, so insulin secretion stops. And you see, because the insulin secretion stops, counter-regulatory hormone has secreted, that's why at 2.5 hours there is a slight rise. Now this 70 can come down to 40, 30, 45, 60, we do not know what is the level. Every individual is having a set point, it is not universal. That is to be done by testing, but not by any imagination. And I have seen it has come down to even 40. Then this counter-regulatory hormone started operating. In this case, you see here 80 is there, still it is coming down. Even the sensor system is not still working. Maybe it will take further time, and I have several such data. I have worked for 3-4 hours, long hours, as long the patient wanted. I wanted to see at what is the lowest limit when his body is responding to hypoglycemia. So here you see again it is falling down. You see again it is falling down. So you do not know how much the fall will be there with the progressive term. At one point of time, we will get this type of figure. From that, it will start increasing because insulin secretion will totally stop. So now this is normal level. No blood glucose is above 180. His blood glucose level is less than 126. So this is an absolutely normal level, and there is no glucose level in the urine. You get my point? So in diabetes, you see the fasting blood glucose is 170. That means it is more than 126. Fasting itself is diabetic. Okay. Now this patient has taken glucose. Or this patient has taken. Now you see the rise here. The rise is 55. Here the rise 90 to 145. The maximum peak is here. Peak may occur 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 here. You do not know. Without testing, this cannot be predicted. That again, I am having an adequate data for this to prove that in this patient, even in a doctor, I have seen the PP level rise was at 3 hours, and I demonstrated it. That this is the reason why you are confused, because your body system is so adjusted such that over for a long period of time, your PP level is reaching a peak at 3 hours. Without doing this test, how can you judge it? You cannot. She was confused. So now you see here the difference I am telling you. Now you see the difference here is 100. See, peak is here 170 to 170. Why is this difference? This is 100, this is 55. That means the insulin level is not adequate, it is not able to bring it down. You see the level, it is 145 to 145 decrease করে দিল জুম করে। এখানে দেখো এই ডিক্রিজ করতে পারে 30 ডিক্রিজ করলো। এর তো আইডিয়ালি আরো বেশি ডিক্রিজ করা উচিত ছিল। এখানে দেখো এখানে ডিক্রিজ করলে 100 থেকে 70 তে ডিক্রিজ করে দিল। এই দেখো 200 থেকে 240 থেকে মাত্র 220 তে ডিক্রিজ করতে পারলো। কেন? ইনসুলিন রেসপন্সটা পুয়ার আছে, সিক্রেশন করতে পারছে না। এবারে যদি এই ফিগারটা 270 থাকে তাহলে এই ফিগারটা তখন 470 হয়ে যাবে, 570 হতে পারে, আমরা জানি না কিছু, না টেস্ট করলে বলতে পারবো না। কারণ 370 হতে পারে, 670 হতে পারে, কি আমি হবে না হয় কোথায় যাই না, সেই ফিগারটা এখানে হতে পারে, এখানে হতে পারে, এখানে হতে পারে, না করলে কিন্তু বোঝা যাবে না কোনো হবে না। এবার তুমি দেখো 170, এখানে কিন্তু কোনো ইউরিন সুগার নেই, মানে থ্রেশহোল্ডের নিচে আছে। এটা দেখো 210-এ ক্রস করে গেছে, 180, সেই জন্য ইউরিনের সুগার 1 পজিটিভ চলে এসছে। এটা দেখো আরও বেশি আছে, সেখানে 2+ চলে এসছে। এখানে দেখো 220, এখানে 1+ আছে, এখানে 220, এখানেও কিন্তু 1+ আছে, এখানে 210-এও 1+ আছে। এটাও একটা ব্যাপার আছে, ইউরিন ভলিউম কতটা আছে। এই পিরিয়ডে পেশেন্টের মনে হয় চেষ্টা পাচ্ছে, জল খেতে চাইছে, মানুষকে জলটা খেতে দেবে, কারণ তোমার ইউরিন ফর্মেশন চাই। Every time the patient is going to the toilet at 30 minutes interval, we do not pass urine, so urine collection will be a difficult issue also again. So ask the patient to drink a little bit water so that you get the urine. And one advice that before you just note down the time after half an hour, at 29 minutes of time, ask the patient take that test tube and go to the toilet. So at 29 minutes time, practically I used to do it, because after giving blood, going to the toilet using the left hand, it is very difficult. So it is best to get the urine sample at least 1 minute before that thing, and then you give the blood every time, so that it will be convenient both for the patient and for the laboratory. ওখানে গেল, আমি দেখেছি, আমি নিজেই এই কাজটা করেছি, রক্ত করতে হলো, তো সম্ভব না করা। ল্যাগ কার্ভ means eliminate type of curve. There is a rapid absorption of glucose. Here this is a normal absorption. See, from 70 it is going to 220, rapid absorption. Why rapid absorption? Either there is rapid intestinal movement. It can happen in hyperthyroidism, where there is rapid intestinal movement. Diarrhea, what happens? Rapid intestinal movement is there. So many patients are having tension also. They are having also rapid movement of bowel, because many are suffering from irritable bowel syndrome. So rapid movement of intestine due to any cause will cause a rapid rise in blood glucose, and you see it's from 70 to 190. So there is a rapid rise, and then body senses that I'm going to get some amount of glucose more, so it will secrete more insulin, and as a result it is coming down to 80. Now in this case what happens, if you do fasting and PP, both will give normal result. But if you do a unit sugar will be positive. Now there will be confusion. Now this will make the picture very much clear. Now one case I got, the first case in my diary, the patient gave this type of result. I did the test twice, fasting and PP, could not realize what is the problem, then I did a GTT. What I understood, the patient undergone a gastrojejunostomy, means normally we are taking food or glucose. It is passing through stomach. There is a pyloric sphincter. There is a delay, gastrointestinal transit delay. It is acting as a valve, and then it is passing through the duodenum, to the jejunum, and then to the ileum. Now, if I make an opening, the stomach along with the jejunum, means we are simply bypassing this thing. So it will be directly entering into the intestine from jejunum to ileum, and glucose will be rapidly absorbed. And that I asked the patient, just I want to examine you. Opened the abdomen and saw a big scar. What operation? Then I went to the medical records, undergone a vagotomy with gastrojejunostomy. Then I explained, you did not tell this thing to me earlier. Otherwise, unnecessarily you have given this blood. So basically, it is called dumping syndrome. Means stomach contents are dumped directly into the intestine without bypassing this duodenum and jejunum. So that can cause elementary type of glycosis. Similarly, another patient I got, hyperthyroidism. This was diagnosed by looking at this type of curve also. The patient was wrongly diagnosed as diabetes and wrongly treated. Again, this was diagnosed as biochemistry department, and from medicine department it was transferred to biochemistry department for treatment and dose adjustment. Actually, many patients diabetic patients, hyperthyroid patient, who cannot be managed by the medical experts, they used to refer the patient to our department, and I used to titrate the dose, and then you to send back to the once it is normal glycemia is maintained, or in case of hypothyroidism or hyperthyroidism, euthyroidism state is maintained, then I used to refer back to the patient. After 8 doses, cholo. So renal glycosuria, you see, as I told you, the proximal convoluted tubule reabsorption is less, so 130 is here. So at 130, ideally blood glucose should not come, unit sugar should not come. But you are getting sugar. This figure can be here also. The patient is not diabetic. So even if you get say 85, 130 here or 140 here, the patient is not diabetic. Patient is normal. But if you get an unit sugar, it will appear that as if the patient is renal glycosis has crossed the renal threshold. No, this is a case of low renal threshold. Same thing can happen with high. In this patient, you may not get any of the urine sugar. So that is called high renal threshold. Means the patient body has adjusted. So even after having a very high glucose level, this type of case is also available in my diary. I got this type of patient also. Last one is flat curve. Now here the insulin secretion is deficient. Okay, because of that thing, it is unable to bring it down. Now those who are secreting more insulin, or those bodies are more sensitive to insulin, like a hypothyroidism. One condition I am telling you, where there is sluggish movement of the intestine and there is high sensitivity to insulin. In that case, you see the rise 75 to 90. You see the rise here. At half an hour, you see the rise here. You see the rise here. 90 to 150, and then 95 to 85. It's almost a flat type of curve, not typical that type of curve. You see the difference between the normal and this flat and this diabetes. So you have to concentrate basically on these first two, and at the best this one, and rarely you will get renal glycosuria type of curve. But you have to be watchful. Only here you will get that if you give that SGLT2 inhibitor drug, then you will get this type of result also. Because you are inducing glycosuria by the drug. Now, if you plot it, you will get diabetes mellitus. The same thing, I am plotting 0 to 2 hours blood glucose level in this side and the hour here. That is basically glucose tolerance test curve. Now, the diabetic patient will have the renal threshold is here 180, and the diabetic curve, this figure will be above this thing, and sugar will be appearing, you will get the diabetic curve. Now, normal curve will be always like this, and impaired will be in between. As you told, somebody wanted to tell the pre-diabetic stage. Somebody has told during my class. So, this is pre-diabetes from here, this stage, from here to this stage, and that to that stage. And that depends on the person's food habit, on the person's genetic propensity, how quickly he will pass from this stage to this stage to that stage. Those who are having genetic obesity, genetic propensity for diabetes, be very careful, get assessed, try to get detected at impaired IGT stage, and then reverse it back into normal. Prefer to see the actual figure rather than the curve. In the figure, you will get the real actual figure. Otherwise, if you give the curve, you have to calculate from the curve what is the actual figure. It is better to have the right straight away the figure itself.